Welcome to the 8-Minute Rule podcast, where actual physical therapists share clinical pearls designed to create conversation around what's getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. Welcome to the 8-Minute Rule, where actual clinicians share clinical pearls designed to create conversation around what is getting results in the clinic. No fluff, no Medicare stopwatch, only quality content. I'm joined here today with fellow Drew and fellow in training Mark. Unfortunately, Lucas is gone for the moment. Technical difficulties got him today. There's been a few runs but we're still persevering through today. We're going to give you guys some quality. Topic for today is going to be posterolateral hip pain. Ideally looking greater trochanter to gluteal aerial, where we're going to be trying to decipher what's going on. Today's topic is going to also focus primarily on subjective and objective. I want to know what questions we're asking, what things we're looking at. If we have time, we'll delve into a little bit of treatment as well. So I got a fancy clock here today. If it'll work, we're going to hopefully use it. 5-second countdown here. And we're sending it over to Drew. What you got?
All right, take 5. So we're going to get started. Again, I think one of the most important parts of the posterolateral hip pain when you're treating that in clinic is working on that differential diagnosis to make sure you're treating the right area. There's a lot of different structures, areas that can refer pain into that region. So making sure you have identified what is most likely causing that and beginning treatment there will help you be more efficient. There is a lot of times where there can be, multiple contributors to this, but if you're hypothesis list and you start ranking them 1, 2, 3, or whatever, then have that top one as either lumbar, hip, extra-articular, those types of things. That'll help you be a lot more effective and efficient.
I like it. How about you, Mark?
Yeah, so I agree. And then kind of how do you get to that point? It really starts with the subjective exam. And if they don't volunteer some of this information, you may have to ask some very specific questions to help you rule up or down some of your hypotheses. So if you're talking about, um, you know, hip, sometimes labral issues will kind of give you that C shape, in which case you'll look for like squats being a provocative thing kind of at the bottom of the squat. If you're thinking extra-articular, usually tendons will have like a warming up effect. So the first few steps are not great. And as they get warmed up, get moving more, they start to feel a little bit better. And then, asking about, how does bending and picking things up feel for them, to help you get a better understanding of the contribution from the spine. And then a couple very specific like hip things is, crossing their legs, and laying on their right side or on whatever side is affected. Can they tolerate any pressure onto that greater trochanter, as well as car transfers? All of those are going to make me think more hip driven versus spine. And then you can dive into each one of those a little bit more and hone in at intra-articular versus extra-articular.
Yeah, I think one of the things that Barb Stevens, who was a fellow mentor, really hammered into me was if you ask trash questions, you're going to get trash answers. And so, like, you can ask questions and not get any relevant information. So when they do say something like, "Oh, it hurts if I sit for a while," that's where you want to dive into in saying, "All right, what does that look like? Is it when you're crossing your legs? Is it when you're just sitting? How long does it take? And where do those symptoms go?" So being inquisitive and not just kind of checking the box on what are the aggravating factors is a key for that subjective piece in the differential.
Yeah, I think that's a really good point. Our questions are going to lead us in terms of what we want to be taking objective measures around. And if we start early with very narrow questions, we're going to lose a lot of information that can be really valuable to us in that examination too. Another thing that had popped up in my head, obviously, age. I don't think we've talked about it yet here, but age is going to be a big factor here. We got that morning stiffness, kind of a little bit of limitation, some range of motion. Obviously, with an individual, we're thinking a lot more towards hip OA than we are some of the other things that could be present here as well too. So, as far as kind of some quick clinical objective measures, well, what are you guys seeing to work when you want to get a lot of information out of kind of less intervention measure there? What do you think, Mark?
So thinking extra-articular, kind of the gluteal tendon issue, a single leg stance of 30 seconds. If that's not provocative, that helps you rule it down a little bit more. And they don't actually have to balance. They can be supported. They just have to sustain that position because the EMG activity of the glutes are really high there, glute med. So that's a quick one for like intra-articular slash like a labral issue, like doing a squat. And then if that's not provocative, a quick screen for the squat at the bottom of it is just have them kind of weight shift from side to side. It's basically like a self scour, and it can help you hone in a little bit quicker into like a labral issue. And then, with all of them, you're going to be looking at like passive range of motion, but with a like an OA type thing, you're looking for potentially following a capsular pattern. Would be kind of an expectation there.
Yeah, I would 100% agree, especially when you start trying to tease them out. One thing that I've seen it, if you have some sort of like a maybe a lateral stenosis or something where you think is coming from the lumbar spine, a lot of times that is associated with degenerative hip changes as well. And I've had a lot of students and other mentees where they'll start doing some range of motion, active range of motion over pressures of the hip. One thing that you want to be cautious is of how does that affect the lumbar spine as well. Particular, I see a lot of times like you're going some overpressure, internal, external rotation, especially that internal rotation. If that patient's supine and you start to take them to end range and push a little bit, and they start to experience some of the pain. Um, I've seen where a lot of times that can be because of some of that like side bending, almost an extension in the a relative extension of the lumbar spine. So making sure that you're doing quality tests and even observing what is moving. If they're at end range and you keep pushing through, what's happening at that lumbar spine? And does that mean, hey, is this hip or lumbar? Because like whatever you're testing is really what you are whatever is moving is what you're testing. And if you kind of blow through that end range because they have some limited mobility in the hips, you're kind of moving up to that lumbar spine as well. So good quality testing is key.
Yeah, and to that point, Drew, kind of what you said in the subjective about crap questions, crap answers, it's kind of garbage in, garbage out on the objective too. Like that's why honing in on like your assessment techniques is so important to make sure you're testing what you think you're testing.
Yeah. So if like even in that scenario when you're doing some of the like bigger picture of like lumbar active range of motion and overpressure as they're typically over in standing and there is a lot of hip movement in that as well. So breaking those down, if you are like, if you're doing some extension and you prop your hip up onto, say it's the right hip, you put that right hip on a stool and then try to isolate some lumbar extension to do some differentiation to see which one most likely is the cause of that can be really helpful. Um, and, if it's rotation, it's blocking hips, just to get a better idea of, do I think this is primarily lumbar or primarily hip?
I like that. I was thinking too about even just differentiating out between, weight bearing versus non-weight bearing. So obviously positional changes, which you guys have hit on a couple things, but one of the things I like to do is obviously have them walking, whether it's on treadmill or whatever have you. Symptoms come on, get them on the tread and get them onto the recumbent bike and just changing position there, seeing either one spinal involvement. Obviously you can kind of see some differences there, as well as just taking the recumbency versus the weight bearing and engaging out those two things. So, but yeah, really like Drew, your point about, both of you guys, quality questions, quality measures. It's not necessarily about doing a ton of different things and creating a lot of different information, but most specifically, what are you doing and what are you gaining from those tests as well?
It's the last 4 seconds. I think one of the biggest things that I learned in that subjective piece of the fellowship was, if you don't get the answer to the question you're asking, dig further. Like, don't just move on to the next thing and get the information that you need.
Love it. All right. Well, I appreciate it, guys. Shout out to Chris Stosky for giving us some love on the Teams channel. So please go check out there and comment. Also, Andrew Swartz
Yeah.
bringing up some good discussion points. That's really what we want out of this. Everybody to be able to talk and to dive a little bit deeper as well too. So, asteroid involvement.
I already used the biopsychosocial ATP component with one of my students. That was a really good way to kind of structure that. So thank you, Andrew. I loved it.
The new 40-year-old is never too young to learn. So we love
That's right.
it. All right. Appreciate you guys. Have an awesome day.
Thank you.